This is lecture 17. Even though it says 2 of 2, this is actually 3 of 3. This is our very last board. Here we're going to talk about lesions, upper motor neuron and lower motor neuron lesions, specifically talking about motor tracts, even more so specifically talking about the lateral corticospinal tract. We're going to discuss Brown-Séquard syndrome, and we're going to go into it. Here, you're just looking at the lateral corticospinal tract. We know that it comes down. It starts in the cortex. It's going to come down through the corona radiata. It's going to go through the internal capsule. It'll come down and descend through the crus cerebri of the midbrain, and then it's going to come down and synapse, or at least cross over at the level of the medulla, and then it will eventually synapse in the spinal cord and go out to lower motor neurons. We drew 2 lesions in here and showed if you have a lesion up top in the internal capsule, which is also down here as well. If you have a lesion in the internal capsule, this is a lesion above the decussation, meaning this is a lesion above where it crosses over. It's going to give symptoms on the left side. What that means is that if your brain is over here, rather, or if you're over here on the right side, and if this is where what would you say? If this is where it's starting from, right?
Yeah, so the start point point's on the right side.
Yeah.
So the lesion, right? If you're saying that the lesion's in the internal capsule like you have it,
Yep.
Then no matter what, wherever the lesion is, doesn't matter if it's located there or down below, if you start on the right side, then you always know that the symptoms are going to be on the left side, and vice versa. So if you start on the left side, the symptoms are always going to be on the right side. Doesn't matter where the lesion is. Now, if you look at the lesion, like you just said, the lesion in the internal capsule, if we're starting on the right side, we said that the symptoms are on the left side. So the symptoms will be contralateral to a lesion in the internal capsule. Does that make sense?
Yeah.
Versus the other way around, if you start so we start on the right side again.
Starting on the right side?
Yep. Now that means the symptoms are always on the left side if we started on the right, right? So symptoms are on the left.
Yep.
If we have that, now if we have a lesion that's below, right, as you can see in the spinal cord after crossing over, then the lesion is ipsilateral to the symptoms or signs.
Yeah, that's perfect. In this case, we're talking now about Brown-Séquard syndrome. Brown-Séquard syndrome we know is it's a hemisection basically from your spinal cord, so half your spinal cord. The hemisection is damaged or destroyed. The 3 tracts that would be affected are the corticospinal, because we know the corticospinal tract is going to come down and it's going to cross over and descend. This is a motor tract. It's going to come down and descend through one of the sides of the spinal cord. So if you do have that Brown-Séquard, that could be affected. Also the spinal thalamic or anterior lateral, which is our pain and temperature pathway, that's a sensory. That going up will be affected, and also the dorsal column medial lemniscus system, which is also sensory, that would be affected as well. And we know those pathways from previous videos. This is going to go into Brown-Séquard as well. We're just going to continue talking about it. We basically drew, if you did have a hemisection on one side of your spinal cord, right, this is the level of the spinal cord, if you had that, and we just discussed what would happen basically. On the side of the lesion, right, so if you have, this is what Jared said, your right side of your brain, right side's going to cross over to the left, down at the level of the spinal cord. If you have a lesion at the left side of your spinal cord, that's ipsilateral to what your symptoms would be, or where your symptoms would be. That's going to show and present itself right here, versus the other side would have no impairment at all. So you just have to walk through this and make sure we understand this guy right here. And then that's basically it. It goes into upper motor neuron syndromes versus lower motor neuron syndromes. Upper motor neuron syndromes are just saying that the actual upper motor neuron, which is what's stemming from the brain before it synapses, that's your upper motor neuron syndrome. That's when you have damage there. And then a lower motor neuron syndrome would present when basically this is not getting any information from the brain. We said this would go first. Usually this would be damaged first, or at least present first. And then 4 to 6 weeks later, the upper motor neuron syndrome would present after that.
Perfect. And then basically just looking back at that, right, if you're on the left side, right, once again, if you're on the left side, then you know that you would have the symptoms on the right side.
Yeah.
So in this case, there would be no symptoms because you don't have an occlusion there. But if you're on the right side, starting on the right side of the cerebral cortex and going to the left side, then you know that the signs will be on the left side. And what we see here in this specific case, with the occlusion being on the left side of the spinal cord, then that means the signs are ipsilateral to the lesion in this case.
Yeah.
But we could have had it on the other side where it would not be ipsilateral.
Exactly. And then we spoke about quadriplegia and paraplegia. We said, to our knowledge, paraplegia, first of all, both of these guys are going to be bilateral spinal cord injuries. So that's super important. The difference between these two is, where is that bilateral spinal cord injury located? Is it at the level of the cervix? Is it in the cervical? Yeah, is it at the cervical region? If that's the case, then it would be quadriplegia, right? Because that's higher up near your neck region. Everything underneath that would be damaged. Or is at the level of your, is it in the,
thorax.
Yeah, the thoracic region, in the thorax. Then basically it would be your legs that would be paralyzed in that case. However, your arms would still have some function. So that's what that depends on. However, they're
So
both.
that'd be paraplegia.
Yeah, paraplegia.
Thoracic would be paraplegia, and then cervical would be quadriplegia.
Exactly. Both are bilateral spinal cord injuries. And then we went on to say that we said bilateral upper motor neuron syndrome is below the lesion. What were we saying there? Bilateral upper motor neuron syndrome is below the lesion.
The bilateral upper motor neuron syndrome. So everything below the level of the lesion, right, which is where you're going to have this injury, is going to be affected.
Okay. And then we continue to say what we were saying before. The lower motor neurons usually go first. At least they present. Yeah, they present first. You have flaccid paralysis, and then 4 to 6 weeks you would see some upper motor neuron symptoms being damaged. So it could be like spinal shock. You would lose all sensory information or all sensory tracts below the lesion, so you wouldn't feel anything from your
dorsal medial meniscus or the interior lateral system pathways.
And then we just have this last guy, which we kind of already spoke about.
Which is due to an infarction, internal capsule infarction. And we wrote the contralateral upper motor neuron injury. So you would see hyperreflexia, extensor plantar reflexia, and spastic paralysis.